Good morning, everyone. This is Diana Arias with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Part 1, The Foundations of Infant and Early Childhood Mental Health. Today's webinar is the first of a two-part offering on infant and early childhood mental health. This webinar will focus on the unique mental health needs of infants and young children and the provision of mental health services for children under the age of 5. Participants will learn about key principles, skills, and strategies, including the importance of attachment, relationships, responsive caregiving, as well as the challenges that can disrupt these processes. Relationships that are socially and emotionally responsive form the foundation of healthy development for infants, toddlers, and preschoolers. Participants will gain a better understanding of the mental health needs of infants, toddlers, and young children and their families, and how to support healthy social-emotional development. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation today. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Wendy Bender, Executive Director for the New York State Association of Infant Mental Health, and Evelyn Blank, Associate Executive Director of the New York Center for Child Development and Director of New York City Training and Technical Assistance Center. Before we turn it over to our presenters, I'd like to let everyone know that by participating in this webinar, you are eligible to obtain one continuing education contact hour. CE are available for social workers and licensed mental health counselors. Please follow the instructions on the next two slides to access the CEs. This information will be in your chat box, so feel free to copy and paste for your record keeping. But very briefly, you will need to create a username on this email address. Log in and scroll down to select today's webinar. You'll then click on Register. You'll fill in the billing information. After registering, you will receive a confirmation email to complete an evaluation. Once the evaluation is submitted, within 24 to 48 hours, you'll need to log back in and go to your registrations. You'll complete an assessment, and once this is done, you'll be directed onto how to download your CE certificate. For any questions, please feel free to contact us at the number listed here or email us directly at this email address. Once again, thank you for joining us. I will now pass it along to Wendy and Evelyn to get us started.
Hi, everyone. This is Wendy Bender. I'm going to just let you take a peek at the objectives that we'll be talking about today. And I just want to mention the luxury of a webinar is that each of us gets to be part of this experience without the daunting task of traveling across this big state. But the downside is we don't get the opportunity to actually be in the same room together and look around and see who else is here and who's interested in this work. There are more than 300 people that have already joined us today, which I find just so heartening. There's such an increasing understanding and interest in the impact of what's happening in early childhood. So I'd like to invite you to all take a moment and just imagining being in this room with more than 300 of your colleagues who share your passion and commitment to doing this work. I want to mention that the part 2 of this webinar is scheduled for Friday, February 16th. And if you find this webinar interesting, make sure you tell your friends and invite them to February, and maybe we'll have 400 that join us for that time. So I want to take a moment just to introduce the New York State Association for Infant Mental Health, or NICE AIM. And it's a statewide organization with multidisciplinary professionals. And what that means is that anyone who works with very young children or supporting very young children and their families, from child care providers, pediatricians, home visitors, teachers, nurses, family court judges, mental health clinicians, supervisors, policymakers, and university faculty and research. This is really a very, very wide range of people. And because of that, we expect that on this call there's a wide range of knowledge and experience here in our virtual room. We plan to cover a lot in a very short time, and our hope is to invite you to relate this to your work, the work that you're doing with young children and families, and hopefully be interested in learning more. So I invite you to also consider joining NICEAIM on Facebook. We are committed to posting infant mental health related content daily.
Hi there, this is Evelyn Blank, and I am thrilled to be joining you today. Thank you, Wendy. I echo your comments, and I want to thank CTAC for the opportunity to really let us meet with all of you. So I want to tell you a little bit about my agency, New York Center for Child Development, and NYCCD has been a major provider of early childhood mental health services through a wide variety of funding through federal, state, city, philanthropic, and all of these programs have been in New York. We also have a long history of providing system-level expertise to inform policy and support the field of early childhood mental health through training and direct practice. And as we talk about infant mental health today, I also want to let you know of some exciting opportunities in New York State as well, and how policy is really kind of changing to really help us to do the work that's just so critical here. New York City was also really privileged to be selected by the New York City Department of Health and Mental Hygiene under Thrive New York City, NYC, to develop a citywide early childhood mental health training and technical assistance program. And we're very fortunate to be have a subcontractor with New York University McSilver Institute for Poverty Policy and Research. And they offer clinic, business, and system transformation supports. I'm sure that many of you through other TTAC webinars have really benefited from their expertise. And we've been really quite thrilled with this partnership. We feel that we're bringing to it a clinical expertise, training expertise, but also really a sense of how do you really support these services and sustain them in the real world, in the business world here. So I just wanted to point out our website, which is ttacny.org, and encourage people to really go there to get more information. We do a variety of trainings for mental health and other professionals and try and post as much as we can to that website. So please check us out, and we look forward to seeing you there. Thank you.
So I want to start us off with a definition. The capacity of a child from birth to age 5 to experience, regulate, and express emotions, form close and secure interpersonal relationships, and explore and learn in their environment. All of this happens within the context of family, community, and culture. And I want you to just take a moment to think of that in connection to yourself or someone else you know. The ability to regulate emotions, form relationships, and explore and learn. These things can be difficult for us, and we're adults. It's really a tough thing for young children to learn and manage, and we're going to talk about how all of that happens, because that is infant mental health. And what we're recognizing is that the foundation for all of this is being laid down in these earliest of years. 85% of brain development is happening before the age of 3. That's kind of scary when I think about it. Early childhood mental health sets the stage for a fragile or a healthy development. And I think it's just important to note that the prevalence range. So we're looking at between 9.5% to 14% of children across the country from birth to 5 that are experiencing some social emotional problems that negatively affect their functioning. And here are a couple of other statistics that are really kind of hard to look at. That preschool expulsion, preschoolers are expelled at a rate more than 3 times higher than children in any other grade. There's a lot of research looking at this and recommending that early childhood mental health consultation may be an effective means for helping to deal with this.
So I want to talk a little bit about return on investment. I'm sorry, I didn't know if you heard me. I want to talk a little bit about the return on investment. And there was a Nobel Prize-winning economist, James Heckman, who actually analyzed the return on investments in children and the return at various stages of the individual's life. And this is really pretty profound, but his findings included that interventions early in the life cycle of disadvantaged children have much higher economic returns than later interventions, and that the highest returns are in the birth to 3 years. So on the next slide, I'm going to show you the graph that he did, and you see that as we get older, the return on investment goes down. And I want to use this as an opportunity to really kind of shout out to an incredibly exciting initiative in New York State right now, which I hope you have all heard about, and if you haven't, I hope you kind of come up to speed with it. But Jason Helgerson, the Medicaid Director for New York State Medicaid, has launched an exciting initiative called the First 1,000 Days. And this is the first in the nation initiative really to develop recommendations for how Medicaid could improve outcomes for the birth to 3 population for those kids on Medicaid. And interestingly enough, in New York State, 60% of all children are covered by Medicaid. So what a profound opportunity. And in line with this, they convened a work group comprised of stakeholders who really went cross systems, cross geography, across New York State. And they were charged in a 4-month time frame, which is actually very quick, to come up with a 10-point plan of actions that Medicaid could undertake to help improve outcomes. And I want to say that as you look over them, they are extremely exciting. They are diverse. They're targeting different child care systems. And I think if implemented, really have the potential to significantly impact on young children. And I'm very excited about this. I want to let people know that if you're interested in finding out more about this, you can go to the New York State Department of Health website where this is posted. It's been an incredibly open process, so that if people have comments and thoughts, please feel free to weigh in. And most excitingly, I want to say that in the executive budget for New York State, there's proposed a $1.45 million investment for fiscal year 2018-19, with hopes of increasing that to $5.8 million in 1920. So for somebody who's been advocating for many years to really have this platform and to see that primary care, education, and that all the child-serving systems are really showing up to recognize why this is such a critical time is extraordinarily exciting. So stay posted, and I hope that you'll all get involved with it and be part of the implementation around this. I also wanted to talk about the Adverse Childhood Experiences study, and I'm sure most of you have heard about this, but I'll do a 101 on it just so that we're all on the same page here. This was a study that was conducted of 17,000 Kaiser patients who were asked about the number of adverse childhood experiences they had experienced in their childhood. And most of these were of an interpersonal nature, so abuse, neglect, exposure to domestic violence. And there were several findings that the higher the number of adverse experiences in childhood, the increased risk of developmental delays, which is really relevant to our discussion today, and that a high ACE score of 4 or more correlated positively with a range of lifelong physical and mental health problems, and also with associated health risk behaviors such as substance abuse, smoking, promiscuous sexual behavior. And if we go to sorry, I went too far here. If we go to the graph here, you can see the kind of progression here that somebody experiences adverse childhood experiences. It disrupts their neurodevelopment, results in social, emotional, and cognitive impairment, and the adoption of risk behaviors, and goes on from there. So I just want to emphasize how important, first of all, early childhood is, but early childhood experiences are in terms of shaping the whole trajectory of life going forward, with consequences in both learning, cognition, and health as well. I want to spend a little bit of time talking about why development in one domain impacts on development in others. And I do this because I think it's really important that we understand that for young children particularly, the lines of development are intimately and inextricably interrelated, and that social emotional development is integral to mastery in all related areas upon which later subsequent development builds. So I just want to say that that competence and competencies developed at each stage really are kind of foundations for the next stage and for children developing, and we'll talk a little bit about that. But I thought I'd give one example of how the domains of development are really interrelated. A child may have a speech delay, for example, and may be unable to communicate or express their needs or feelings, and sometimes may resort to aggressive behavior or tantrums when they're angry or frustrated. And what may be perceived as a behavioral problem may have its roots in an inability to effectively express those needs. So as we talk about evaluating young children, we often talk about a multidisciplinary evaluation where we're really looking at all the domains of development. So particularly for young children, we can no longer think of mental health and development as separate, but rather intertwined, and that the comorbidity between mental health and child development is very well established. And I want to pause for a moment because oftentimes I find that professionals who are providing mental health services to young children do not have a solid grounding in terms of typical and atypical child development. And I would strongly encourage anyone who is working with young children to really come to understand that and to understand the interplay between normal development and social emotional issues. And also for children with developmental delays, we often fail to recognize the foundational importance of the social emotional domain and the co-occurrence of mental health and development disorders. And I want to say that this has been an issue in early intervention and CPSE, where one of the 5 domains of delay is social emotional, and yet oftentimes this is a domain that has gone overlooked. So for example, you have a child who's experienced severe trauma, and when they get evaluated, it turns out they also have a speech delay, and they end up with speech services, but not really addressing the underlying trauma that's there. But on the positive note, because I'm a person who gets very excited by policy initiatives, I'm pleased to announce that the New York State Department of Health, the Early Intervention Program, recently released a guidance document for EI and other professionals that's entitled Meeting the Social Emotional Development Needs of Infants and Toddlers. And it's really targeted to really help people to identify and to assess and to treat social emotional concerns in the early intervention program and other systems. And again, if you haven't seen this, I'd encourage you to go to the New York State Department of Health website where you can download a copy of this. And I think it's really important that this gets circulated and disseminated, not just in mental health, but really across child-serving systems. I also wanted to say that I'm excited to say that the New York City Early Intervention Program is about to release 3 videos that were, webinars that were developed in partnership with New York Center for Child Development on atypical and typical social emotional development. And for those who are interested in this, it should be posted on the EI website, but we will also post it on the TTAC website as well. So I encourage you and I encourage your staff to really go there. I think it provides a solid foundation, and I think it's really essential in terms of providing mental health services for young kids. I also want to talk a little bit about the science, and we'll talk about this a little bit more later, but there's actually been RAIN research showing that chronic stressful conditions such as extreme poverty, abuse, severe maternal depression, or other trauma can disrupt the architecture of the brain and lead to lifelong difficulties without the buffering protection of a nurturing adult. And we're going to spend a lot of time to talk about the importance of relationships today. And that children exposed to serious early stress develop an exaggerated stress response with long-term physical consequences ranging from heart disease to depression. And I'm going to show you a brief video here, and I just want to give a call out to the Harvard Center for the Developing Child. And this is another exceptional resource, and they are really kind of at the forefront of really kind of integrating policy and theory and trying to present it in a way that really is kind of quite concise and quite succinct. And they have a variety of materials, very helpful if you're training your staff or also in terms of advocating for some of the policy changes that I think that we need. So I'm going to go to the video. So I just want to say that I think that what this video really demonstrates is just the critical importance of relationships in terms of buffering toxic stress, and that toxic stress actually has physiological impact on the child and on brain development.
So this is Wendy. I'm going to jump back in, and I get to talk about the importance of relationships. And as you all know, children's lives are built around primary emotional relationships. And I love this quote that says, "There is no such thing as a baby. If you set out to describe a baby, you'll find yourself describing a baby and someone." But we're going to watch a video. This is a video it's called reference to the still face experiment. So some of you may have seen this or another video of this, but I think it is just an amazing thing to get to watch. So let's take a peek. Okay, I have seen that video 100 times, and it is still hard to watch. And I think one of the hardest pieces for me is recognizing that what we got to see happens for young children all of the time. We got to see a very slowed down version, a real close-up picture of what this is that is happening for that young child. But this happens between parents and children all the time, all day long. And it's impossible to be totally attentive 100% of the time to what a child is needing and asking for in any moment. And it's important to recognize that it's okay that we're missing some of those cues and that we're not able to respond immediately. What is happening with this little girl is learning how to manage that stress And when her mama returns to her and they reconnect, that repair has a huge part of their relationship. That repair is what allows that young child to begin to learn that, okay, this was horrible and I didn't like this at all, but it's going to be okay. And my relationship with my mom is what's teaching me that this is going to be okay. So this next slide, you notice the first bullet, we're back to mentioning that definition of infant mental health. This relationship has an impact on all of those areas: regulation, learning and exploring, and relationships. In order to understand a young child, one must understand the parent and the child. And in treating young children, one must work from the context of the relationships, and most treatment for very young children is dyadic, involving caregivers. Infants are wired. Attachment tells us that a baby is wired. Have you ever noticed a newborn baby, if you put one of your fingers into the baby's hand, how he was going to grab and hold on tight? You're witnessing the attachment system. He needs you, and he is an active part of letting you know that that's what he needs. So with attachment theory, we're recognizing that these patterns of avoiding and approaching, that these relationships that we see in adults are rooted in these early childhood relationships. Attachment styles tend to be transmitted intergenerationally. These are early experiences become our inner working model, how we see ourselves, how we see others, and how we see ourselves interacting with others. Without conscious thought, it becomes part of who we are, and it becomes part of how we're going to parent. And I'd like to ask you, have each of you been in the midst of doing something at some point in your life, and you stop yourself in your tracks and you go, oh my God, I'm my mother or father or other caregiver? That's what this is all about. Those parts of you that were part of your early upbringing become part of who you are. Parents play many different roles in the lives of their children. They're teachers and playmates and disciplinarians. But of all of the roles, the role that has the most importance in predicting a child's later social or emotional outcome is the role of an attachment figure. So attachment is a specific aspect of the relationship between the child and the caregiver that's involved in making the child feel safe, secure, and protected. Attachment is talking about when the child uses that caregiver as a secure base from which to explore, and when necessary, as a haven of safety and a source of comfort. You've seen this if you've watched a 1-year-old toddle away from her parents and then pause to turn around and look back, catch an eye, and then toddle off to play some more. And you've also seen it when that toddler falls and looks needingly to that parent for comfort. When a child has consistent, safe, emotionally attuned, and available communication with their primary caregiver, the result is the child experiencing feeling connected, understood, and protected. And this is really working. This is from the work of John Bowlby. And I want to mention Elizabeth Ainsworth, who really worked to help us break this down in terms of what it is that we're seeing and the different types of attachment. So we're going to talk about these a little more specifically. And it's important to note that as we do, we're not talking about what the individual child brings. It's not about the child and the child's temperament. A child can be shy or moody or easygoing. That's what the child brings to this. But the attachment is talking about the relationship. So a secure attachment, this is healthy and typical, and is characterized by children who you see that joy as they reunite with parents. that they're free and comfortable that 1-year-old that is comfortable being able to explore their environment with just a glance back at caregiver, because I know you're going to be there. This is all going to be okay. And that I know it's safe, that I can express my needs when something happens. And with a lot of research, they're seeing that about 70% of all children fall into this secure attachment. As we get into talking about an insecure attachment, I think it's really important that when we look at the challenges in those relationships, we're really careful that we're not going to blame a parent. When I asked you earlier about the, oh my God, I'm my mother experience, you're not to blame for that, and your parent is not to blame for that. Those experiences come from each of our early experiences, and they become part of who we are. So when we talk about the insecure attachments, the first one we're going to talk about, and we're covering this very, very briefly, I think an important piece that I want you to take a notice of in that top part, it says that the child experiences the caregiver as. And this is really critical because this is a relationship. A caregiver may have different relationships with different children. And so what one child experiences may be different than what another child experiences. I often say, when I talk about siblings in a family, I often say that no two children ever have the same parent because those experiences can be very different. The important piece to just mention when we talk about an insecure, avoidant attachment is that this is the child who has recognized that it's not safe to express when I'm upset, when I have a need. And so I've got to figure out how to do that myself. You might look at this child and think, oh my goodness, he's really independent or very precocious and really just doesn't really need someone else with him. And when stressed, this child is internally exhibiting as much stress as another child who is screaming and crying. They're just learning that that's not what you do, that's not how you express it. And this can account for up to 15 to 20% of all children. And there's an insecure, ambivalent, or resistant attachment style. This is also insecure, and this child experiences their caregiver is inconsistently attuned. So it can be it can be times when it's really very nurturing and very intently involved, and other times when just not there, not present at all. Okay? This child ends up feeling very insecure, anxiety, and often internalizes their experience. And this can be up to 10% of all children. And then there's a disorganized attachment. This is the child that experiences their caregiver as chaotic, frightening, and disoriented, very unpredictable. A disorganized attachment really tends to be transgenerational. And I want to point out at the bottom the difference in the percentages, because what research is showing us is that it really depends on the population that we're talking about. So in looking at white middle-class children, percentages are showing up between 12 and 15% of children that have a disorganized attachment. When they're looking at adolescent mothers, the rate jumps up to maybe 30%. And when we're talking about infants from mothers who were abused and have psychiatric illness or substance abusing, those numbers can go as high as 70 to 80%. A key thing when you're talking about when you're talking about disorganized attachment is that you're typically looking at a history of abuse and unresolved trauma.
So this is Evelyn again. I wanted to talk a little bit about maternal depression, and obviously we don't have the time today to go into all the kind of impact of adult mental illness or substance abuse on a child, but I think what we've been trying to convey is the critical importance of the caregivers in young children's lives. And we know that 10 to 20% of mothers experience postpartum depression, and this really profoundly impacts on the ability to parent. It compromises the mother's judgment on supervising health and safety issues. She may be less likely to be affectionate or to talk or play or interact with her child, which of course has a very negative impact on the development of not only the attachment relationship, but also the child's development. There's a term we call serve and return, which is kind of the back and forth between the mother and the infant, and oftentimes this is quite impaired. And we saw the still face video, so think about a mother who's emotionally unavailable on a kind of chronic basis and how that might impact on the child's ability to develop and really kind of develop a secure attachment there. We know that where children are raised with mothers with severe maternal depression can lead to developmental difficulties and also delays in impaired social development. And the reason why I singled out this one piece is that maternal depression is absolutely treatable. And I've been very involved on kind of the advocacy level on emphasizing the importance of screening for this and early identification. And because I'd like people to know some of the kind of positive things that are going on statewide, I just want to touch on a few great things that are happening right now that I think will really help us in terms of helping to ameliorate this issue. First of all, I want to note that one of the 10 proposals under the first 1,000 days that I mentioned before is to have the parent caregiver diagnosis as eligibility criteria for dyadic therapy and be able to bill under the child's Medicaid number. Pretty profound. New York State also recently revised their guidance to allow billing for maternal depression screening in primary care through the infant's Medicaid identification number, so that you don't have to open up a separate chart for the parent, and that payment goes beyond just the typical well-child visit reimbursement. And there's also a very exciting section in the report on the status of New York women and girls 2018 outlook, which is where Governor Cuomo includes an initiative to support healthcare providers in the delivery of care to mothers experiencing maternal depression. And it's got several bullets of what they're really prioritizing here, but it's going to have a campaign around maternal depression. DOH and OMH will advance specialty programs, and they're going to develop policies requiring health insurance to really cover this. So if you'd like to know more about this, it's posted on the New York Gov website, and you can download it. But for me, this is just extraordinarily encouraging and really hopefully will help us to get to parents at a point where we can have real impact. So you've been hearing us talk about the intergenerational transmission of trauma and how this is kind of passed down. And I just wanted to kind of highlight a seminal work in the field that we've kind of drawn on over the years. It's called Ghosts in the Nursery, and this was done by Silver Freiberg and her colleagues in 1975. And she introduced the metaphor of ghosts in the nursery, which she was using to describe the ways in which parents reenact with their own small children scenes from the parents' own unremembered, and that's an important word, early relational experiences of helplessness and fear, and transmit child maltreatment from one generation to the next. So, for example, a parent may show negative attributions to a child where they are confusing some of their repressed past history with their relationships in the present. So what would be an example for a parent who said, oh, he's just like his father, or he hates me, which is clearly not coming from the child, but they may be reliving their repressed past painful relationships and projecting these onto the child, reenacting the earlier relationships and thereby repeating the intergenerational transmission of treatment. So this is a vicious cycle. And then, on a positive note, Alicia Lieberman, who we're going to talk a little bit about in the next webinar, and she is one of the people who developed child-parent psychotherapy, which I think is one of the most effective and profound treatment of trauma in young children. And she talked about angels in the nursery and also realized that there were positive caregiving relationships in the parents' past where they may have felt safe, accepted, and loved, and that these can really be used and kind of channeled in helping to break the cycle of maltreatment. And so she saw uncovering angels as well as exercising ghosts in the lives of traumatized parents as very growth-producing work in the work of psychotherapy. So, and we will talk a little bit more about this in the next webinar. So I wanted to touch briefly on the term complex trauma. And complex trauma describes both the child's exposure to multiple traumatic events, which are often invasive, interpersonal in nature, but also the wide-ranging long-term impact of the exposure. And because the exposures occur within the child's early caregiving system that's supposed to be the source of safety and stability, that it can really have profound impacts. And since the child's relationship with the caregiver is so central, it interferes with the child's ability to form a secure attachment bond. And this goes back to what Wendy was talking about the need for secure attachment. The greatest source of danger, unpredictability, and uncontrollability for an infant or a young child is the absence of a caregiver who reliably and responsively protects and nurtures the child. So the lack of a sustaining regulation with a primary caregiver puts the child at risk for inadequate development of the capacity to regulate physical and emotional states. So really just to say again that it all really comes back to a caregiver. And for the sake of time, I want to touch briefly just on the kind of aspects of child's development that can really be impacted by complex trauma. And I think that we've gone through some of these, but I'll just highlight a few of them. So for attachment, it can result in uncertainty about the reliability and predictability of the world. They've had inconsistent parenting, distrust, problems with boundaries, social isolation. On the biological level, sensory motor developmental problems, hypersensitivity to physical contact, and even medical problems. These children may have problems with affect regulation, difficulty with emotional self-regulation and describing feelings in their internal experience, dissociative kind of reactions, and behavior control. So this is an important one because oftentimes this is how this is expressed by a child. So poor modulation of impulses, self-destructive behavior, or aggression towards others. It impacts on learning, on cognition, so difficulty in attention regulation, executive functioning, lack of a sustained curiosity, problems with processing novel information, and certainly in terms of self-concept as well. So lack of a continuous, predictable sense of self, a poor sense of separateness, low self-esteem, shame, and guilt. So these are really devastating consequences, but one of the most critical factors for buffering the impact of complex trauma is positive attachment and connections to emotionally supportive and competent caregivers in the family and the community.
So I just want to talk a little bit about resiliency because we don't want to end with the horror and the scary parts of this. We want to make sure it is honoring that there is a component of resilience and hope. But before I really get into that, I want to mention something about implicit memory. And I've often heard somebody share something with me that sounds something like this. You know, if this child had experienced this horrible situation, at least she was too young to remember it. So what we know from implicit memory is that we store memories that we don't have a conscious recollection of. They're very young children who are very sensory creatures. They may not have that memory in words or a story, but they may be carrying the experience. So we've walked through attachment patterns, we've learned of new ways relating to our children, and we're able to understand and look at the ghosts and rely on those angels as a way of making meaning of our own story. We humans have an amazing capacity to change things about ourselves. It doesn't happen easily, and it's a lot of hard work, but there's an amazing capacity for change. When we support that change, that cycle, that generational cycle can be broken. This child can grow up with different experiences and become a different parent. Just point out the brain plasticity, that young children, that their brains are better able to make new connections with new and different experiences. And I just wanted to include a nod to some work being done on protective factors. So this is some research being done at the Center for the Study of Social Policy, and looking at even when there is significant stress, these factors are known to serve as buffers. And I offered you a link to a handout that might be helpful. And my last piece on resiliency is just the care and compassion of all of you. Thank you.
So as a summary, I think what you're hearing is it's all about relationships when we're talking about early childhood, and that young children really are very dependent on their caregivers and that they develop really in the context of relationships. And quoting Jack Shonkoff, the quality and consistency of early relationships sets the stage for a sturdy or fragile existence. So I hope today what you're walking away with is understanding the critical importance of birth to 5, understanding what's unique about working with young children, that it's not just an aging down of older children, and knowing that not only can we intervene early, but that we can really have significant impact, and that we need to work in the context of relationships. And I hope that we also gave you a glimpse into some of the kind of positive and exciting initiatives that have really helped set the stage and give us the opportunity to really begin to address this in a more kind of systematic and comprehensive way. And I just wanted to end by talking about coming attractions. I think Wendy had talked about an overview of the second webinar, and I just thought I'd let you know kind of what we're planning to cover. And today we talked a lot about the theory, but we want to talk about what are clinical skills, competencies, and practices that are needed to address infant mental health. And what does that practice look like? And what are some of the evidence-based practices that are currently being used? We're going to talk a little bit about reflective supervision, why it's important, and also about an infant mental health endorsement system which has been adapted by New York State. What are the requirements and how you too can participate in it? So I want to leave time for questions here, but I want to thank everybody. We're really excited about the work going on, and we're excited about the momentum. So thank you.
Thank you.
Thank you, Wendy and Evelyn. We are going to begin answering the questions submitted during today's presentation. So as a reminder, you can still submit questions through the chat box. Our first question is, from the very beginning, can you please repeat the name of the early intervention program you mentioned that was mentioned in the New York State budget?
The early intervention, we're talking about the first 1,000 days of Medicaid, I'm sorry. And if you Google that, you can come up with the link to the Department of Health website. So it's the first 1,000 days on Medicaid.
Great, thank you. Are you available to do presentations and or trainings at a foster care agency?
We would love to explore it. So I think that, not speaking for Wendy, but certainly reach out to us. We'd be happy to kind of explore it.
Okay. Great.
Nathan is very committed.
Let me also note that Wendy is upstate. She's up in Albany, and I'm down here in New York City. So we really, we've got some geographic spread as well. So just so you know that.
Okay, great. So you can certainly email us, and we'll forward your email address along those lines and put you in contact in case anyone does want to reach you. Thank you. So let's see. Moving on with questions, because there are a lot here. Having many siblings at home can also be a reason that a child could be all over the place or disorganized. So this is more of a comment and a question. Would that be something to consider in terms of sibling and household composition?
I think that, you know, children develop in the environments in which they're raised, and I think that that's another whole factor that needs to be considered in terms of the well-being of young kids and kind of what some of the factors are contributing to it. Important point, though. Thank you.
Great, thank you. Can life-threatening illness and hospitalizations in early infancy cause toxic stress?
Absolutely. It's the child's experience. And again, that relationship with a parent can serve as a wonderful buffer. But yeah, those kind of experiences can be very traumatic for children. And we need to try to help them through those experiences as much as we possibly can.
Actually, Meredith Wiley wrote an incredible book called Ghosts from the Nursery, and she talks about some of the early childhood medical trauma and how it really impacts on young children. So I'd highly recommend that as well.
Great, thank you. So I know we've been focusing in terms of, you know, children, but here's a question in terms of pregnancy. What would be helpful to a client that is pregnant, seemingly depressed, but is in denial?
Oh, what a big question.
Yeah, I mean, I think that it's really important to really help the parent to understand their feelings and also understand kind of what steps can be taken. I think that part of what it is that oftentimes people aren't aware of it or aware of the impact. And obviously for a pregnant mother, I think it's very important that, you know, before the child is born, that she seeks the right help and supports. There are depression screening tools that can be used to also kind of help the parent to recognize that as well.
Great, thank you. Let's see, our next question is didactic therapy recommended to commence before a mother gives birth?
it can certainly be helpful. And I mean, even if when you're thinking dyadic therapy, even if the baby hasn't been born, it is recognizing that there is a relationship that already started. So yes, can be helpful.
And, we were talking about growth in the nursery also, so really kind of the parents' expectations, their kind of what they're perceiving with the baby. There can be a lot of work that can be done also. And we certainly feel that starting at birth is too late, so we think it's great the sooner you can really intervene.
Exactly. Thank you. And let's see, how do parenting techniques such as cry it out impact the child's development?
Well, thinking about the slides that we just looked through, think about the impact on that child who is learning to say, okay, nobody is coming here, and I'm going to have to figure out how to manage this stress myself.
All right, thank you. So let's see, the next one is, you stated that the PPD can be paid for through the child's Medicaid account. Is there a limit to the number of visits? And can you please send the government link, if possible?
Yeah, in terms of the limit, I mean, it's really dependent on the payer source, and I don't know that I can answer, is there any set limit? I think it depends on the usual mechanisms for determining kind of what's needed and going, whether it's managed care or regular Medicaid, et cetera, but I'm very happy to send the guidance document. And also, just I want to say, for the first 1,000 days of Medicaid, that's something that's a work in progress. That's the recommendation that has to be really kind of worked out and implemented. That's something that's just a recommendation at this point in terms of the dyadic work being billed under the child's Medicaid number.
Thank you. And what is the recommendation for dealing with a toddler under the age of 3, along more in reference to any sort of tantrums?
Well, I think it's always important to really kind of do an evaluation, observation, and try and understand what the tantrums are about. And, I had used the one example of a child who's speech delayed, who has difficulty communicating their needs and oftentimes expressed that way. I mean, I think that looking at the child, seeing what triggers it, see what else is going on in their life, figuring out how the parents are responding to it. So I think it's really multi-level, and I think that we can't assume that there's one cause or that it's just a behavioral problem that needs to be addressed in terms of managing the behavior. So the better we understand what the cause of that is and the better we can figure out what the right intervention is.
Great, thank you. If you can, what is the name of the article on the early intervention website on typical versus atypical development?
That is going to be 3 webinars, and if you go to our TTAC website, probably in the next week or 2, you'll be able to get the link to that. So it's ttacny.org, and we will post the link to those webinars. The guidance document that I mentioned was Meeting the Social Emotional Development Needs of Infants and Toddlers, and that's on the New York State Department of Health website. So if you put in Social Emotional Development Needs of Infants and Toddlers, it will come up.
Thank you. And then last question, just due to time constraints. So let's see, what do we have here? Due to resiliency, there is hope in the form of protective factors. Is that something that you would agree with, or any comments or suggestions around that?
I absolutely agree with, and research is really showing that when those protective factors are present, and those are things that all of us can be doing to help strengthen those and support parents and families in strengthening them for themselves, that when those protective factors are present, we see better outcomes for children.
Great. Thank you for all this useful and important information. Before we end today, I do want to remind you to access the One Continuing Education contact hour for those social workers and licensed mental health counselors. Again, the instructions are listed here on the website, but they are also copied into your chat box. So again, just make sure to copy and paste that for you so you can have for record keeping. Very finally, I do want to call attention to some upcoming events that we have. Certainly feel free to visit our website, ctacny.org. And then very lastly, I do want to thank again Wendy and Evelyn, and thank you everyone for attending today's webinar. If you have any other questions, please contact us at ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of CTAC and our presenters, thank you for joining us today, and have a great rest of the day.